Good evening. Thank you for joining us. I'm Dr. Kathleen Gibson. I'm a vascular surgeon at Lake Washington Vascular Surgeons in Bellevue, Washington, and I have a co-moderator with me today, Dr. Saher Sabri from MedStar Georgetown University Hospital. He's an interventional radiologist, and we're very happy to be having this webinar with you this evening entitled Bridging the NIVL Evidence Gap, a conversation with the authors of the VIVA, AVF, AVLS consensus statement. This webinar is presented by the VIVA Foundation. This is a not-for-profit organization that's dedicated to advancing the field of vascular medicine and intervention through education, research, advocacy, and philanthropy. In addition to our educational conferences and webinars such as this, the foundation convenes a vascular leaders forum and supports important endovenous or endovascular trials. Some of the methodology of this consensus panel and statements is presented here. So in 2023, we had a NIVL roundtable of 12 leading physicians, and the purpose of this roundtable was to facilitate an independent, multidisciplinary explanation of the current state of the NIVL evaluation, management, and follow-up. We next wanted to review the current data and gaps in the literature and achieve consensus through expert roundtable discussions. The roundtable participants then broke into small groups to present consensus statements to the larger group, and the statements were then workshopped with the larger group, followed by a vote of yay or nay. After this, several drafts of a paper were circulated with a final group vote to ensure consensus prior to publication. Over the next hour, we're going to be hearing from some authors and participants in this roundtable discussion. And the upcoming presentations are going to include patient selection for NIVL stent placement, imaging considerations for NIVL diagnosis, technical considerations for NIVL stent placement, optimal medical therapy and surveillance for patients with NIVLs, and future directions in research and education. So I'm very happy to have many of esteemed colleagues and friends here on the panel tonight, including Dr. Kush Desai, who's from Northwestern University Feinberg School of Medicine in Chicago, Dr. J. Mathews at Manatee Memorial Hospital, Bradenton Cardiology Center, Dr. Raghu Kolluri, who's from Ohio Health Riverside Methodist Hospital, Dr. Steve Elias from Englewood Hospital and Medical Center, and Dr. Erin Murphy at Sanger Heart and Vascular Institute, Atrium Health. So all of these presenters span, again, a multidisciplinary panel of interventional radiologists, interventional cardiologists, vascular medicine physicians, and vascular surgeons. So during this presentation, my co-moderator, Dr. Sabri, is going to be monitoring the live Q&A. So we really want you to participate by submitting questions through the chat. And we're going to kick off with 3 presentations in a row. They're going to be by Dr. Elias, Dr. Desai, and Dr. Murphy. Then we will take 10 minutes to do a roundtable discussion and answer some of your questions. The last 2 presentations will be from Dr. Mathews and Dr. Kolluri, and we're going to finish off the webinar with another Q&A session. So without further ado, we're going to first listen to a presentation by Dr. Elias.
Okay, welcome everybody. We're going to talk today, obviously, about NIVL disease and our consensus statement. But one of the most important things before you even think about treating the disease is really selecting the right patient who has NIVL disease for possible stent placement. And that's really what I'm going to go over. So a few things to remember. Placing a stent is easy. Deciding when sometimes can be hard. It's not always quite obvious. And vein disease, it's rarely life-threatening. It's rarely limb-threatening. So when you're thinking of what are you trying to accomplish with patients, you got to realize in general, you're not saving their life or limb. And stent complications can occur. There's thrombosis, there's migration. You can turn a patient who's a mild C3 patient with swelling into a post-thrombotic patient if you have a stent thrombosis. Or you actually may have a patient that's alive, and if the stent migrates to the heart, then becomes a dead patient. So we want you to really understand the indications and which patients really would benefit from placement of a stent in the NIVL patient, and maybe which ones really should not have anything done. So bad things can happen. Here you can see the stent migrating into the vena cava or up into the heart. And in general, it's not the stent's fault. It's really the fault of either your judgment as to who to do or the judgment as to what size stent and what length of stent, which is not the topic of my talk. So in general, we want you to understand you need to treat the patient and not the images. And there are things to ask yourself when you see any patient with vein disease, but certainly a NIVL patient. Are the symptoms and exam seem to you to be venous related? Meaning, does it make sense that what they're telling you may be a vein problem? And if you don't think so, then you stop. You don't even get any imaging because it doesn't matter what the imaging shows. You've already decided that the patient's symptoms are not due to vein disease. If you think they are, well, then you keep going. And you ask the patient things about how it affects their quality of life. Remember, this is not a life or limb-threatening problem. It's something that you want to improve their quality of life. And if they say, hey, that doesn't bother me all that much, there's no reason you need to do anything else. And again, you don't need to get any imaging because you've decided it's not affecting their quality of life. Now, if it does, well, yeah, then you go and you do get your imaging. And when you get imaging, does it show a significant NIVL pathology? And we'll talk about what's significant and not in other parts of this meeting here. But if it doesn't show significant pathology, so some pathology, then you stop. These are not the patients who you want to consider placing a stent into. But if, yes, it affects their quality of life, yes, the images show significant pathology, then you keep going. And now let's get into the consensus statements. So when you have the discussion with the patient, you're going to discuss some things before stent placement. One, you want to let them know what, can they expect regarding the outcome? What are their post-stenting responsibilities once a stent is put in? What do they need to do to come back for imaging and let you know if there's a problem? And what are your post-stent responsibilities? Be aware of that. And you also let them need to know what happens if they don't have a stent placed. Is something bad going to happen? So there are 5 consensus statements regarding patient selection. 3 of them we list as it is maybe appropriate to place a stent. 2 of them we say it is not appropriate. But if you can see, none of them say it is absolutely appropriate. And here's where your judgment comes in. And this really reflects the current available literature. So consensus 1, maybe. Well, stent placement for NIVL may be appropriate in the presence of asymmetrical edema affecting a patient's quality of life after you've excluded everything else, other systemic causes of edema and or lymphedema. Asymmetric affecting a patient's quality of life. Maybe, again, consensus number 2, may be appropriate when you have progressive disease or advanced disease and or venous claudication. So again, persistent venous ulcers after you've taken care of everything else, superficial disease, periulcer varicosities, et cetera, it may be appropriate in those patients with advanced disease to place a stent. Again, number 3, stent placement may have a role in some cases when chronic pelvic pain, when it does impact, again, their quality of life, and that's really the theme you're seeing here, in the presence of dilated parauterine veins, with or without ovarian veins, say reflux. But in my mind, I think you need to be sure that those parauterine veins are coming from the internal iliac vein, which is refluxing down into the pelvis because you have proximal NIVL obstruction and compression. When it is inappropriate, it is inappropriate, obviously, with minimal or no symptoms, and that's what we said before. That's why you talk to the patient before you get the imaging, because if they have minimal symptoms, you don't even care what the images show. Inappropriate, again, for prophylactic stent placements. Unfortunately, out there in the community, there are some people saying, oh my goodness, you have a narrowing, we better fix it before you develop a DVT. There is no evidence for that, and it is inappropriate to place a stent in these types of patients to prevent any thromboembolic events. In the opposite direction, yes, there are people who have a thromboembolic event who you uncover a significant NIVL. Those are people perhaps that, yes, you're now going to treat the underlying pathology because they've had a complication. And in general, another additive factor is needed, meaning, travel or surgery or some other reasons why they would have a venous thrombosis. The NIVL may be always there and you add something else. So again, you only place it, think about it, if you've uncovered a problem, but you don't place it for prophylactic reasons. So what can we accomplish in the right patient? Edema and swelling in general show the least improvement. They show improvement when you do it for the right reasons, but you're not going to turn somebody with swelling into a perfectly normal leg. Pain and venous claudication in general really do get some significant improvement, as does ulcer healing. And pelvic pain, most of the studies show that it's kind of a mixed situation, and some people may wind up also needing their ovarian vein handled in the future. So just want to give you an idea when you're talking to the patient what you can accomplish and perhaps what you can't accomplish. In stenting, the stakes are higher. They're harder to take out. In superficial disease, yes, you may have ablation-related thrombus extension, minimal risk of PE and death. In the NIVL, as we said, you can turn them into post-thrombotic. There's post-procedure back pain, bleeding, contralateral thrombosis, and again, you can have a dead patient. If the stent migrates. So in conclusion, assessment before the stent, treat the patient always, treat the image almost never. When the patient and the image and the history, the physical, all fit, these are the ones you want to treat. If you're unsure, should I treat superficial or deep? In general, superficial first. You can always stent later. So appropriate assessment before stenting is key to success after. Most battles are won before a single shot is fired. Thank you very much.
Hi, my name's Kush Desai, and I'm pleased to speak to you all about the imaging considerations for the diagnosis of NIVL from the VIVA AVF AVLS consensus statement on the management of nonthrombotic iliac vein lesions. These are my disclosures. So, with respect to the consensus statement, we're going to be discussing the imaging considerations for not only the diagnosis of NIVL, but their impact on procedural planning as well as clinical outcome. We'll also review the 5 imaging statements from the consensus document with a brief overview of the rationale, as well as some clinical context. When we talk about the imaging diagnosis of NIVL, we consider both non-invasive and interventional or invasive modalities. Non-invasive, we specifically will cover duplex ultrasound as well as axial imaging, but the primary method by which NIVL has been diagnosed, both historically and in current practice, is through the use of interventional means, including intravascular ultrasound and venography. The use of imaging to diagnose NIVL is primarily from the work of Raghu and Neglin and focuses on intravascular ultrasound, demonstrating that IVUS specifically provides greater detail on venous luminal pathology relative to venography. The 2002 study suggested the sensitivity of venography in comparison with IVUS for detection of a stenosis over 70% was only 45%. IVUS was also better to identify wall thickening, synechia, and trabeculation. The 2002 study was the first to really put out the concept that 50% area reduction, which has now become the dominant metric by which we judge lesions to be symptomatic or significant, was put forth. There are now multi-center efforts that demonstrate IVUS is more sensitive than venography in the detection of stenosis. This is from the first publication of the video trial, with these 2 figures demonstrating that IVUS detected stenosis better than venography and was subject to lesional severity underestimation when you used venography alone. IVUS identified 30% more stenotic lesions of over 50% severity, and was when compared to venography alone. But if you look at a subset analysis of the video trial, specifically looking at NIVL, in the C4 through C6 patients, 100 were totally enrolled, but 48 of them had NIVL. And on the subset analysis, they found that non-thrombotic lesions that demonstrated over 61% diameter stenosis yielded positive outcomes post-intervention. And specifically, area stenosis, the 50% area that has been commonly used, was not predictive of future improvement in this small multi-center trial. How about normal physiologic venous dynamics? We know that veins are far more sensitive to pressure and volume changes than arteries. A patient's hydration status, their volume status, respiratory phasicity, intra-abdominal pressure variations, amongst other things, can significantly change how a vein looks when we're doing a procedure or evaluating a lesion. And so we need to consider all of those issues when we're evaluating that patient. Fixed lesions, on the other hand, in a vein are not as affected by these variables. And so when we see a patient with the appropriate clinical symptoms and a fixed lesion, we're much more likely to consider that a real lesion. To illustrate this as an image from my clinical practice, you can see that this is a patient that has an intravascular ultrasound in their intravenous cava. And if you were to consider the image in isolation on the left, you might think there's a stenosis. However, if you watch this under steady state, you can see that the cava both expands and contracts with respiratory variation. And so the impact of respiration on how a vein appears on intravascular ultrasound is very significant, and you must consider this when evaluating the patient. So does venography have a role in evaluation if we've said up till now that IVUS is far more sensitive for a lesion? My argument is yes. When you see collaterals like you see in these images, hypogastric reflux, visualization of an ascending lumbar vein, visualization of a median sacral vein, such as in the middle picture, these all add confidence to the diagnosis, specifically when symptoms that are attributable to this lesion are present. And finally, can compression exist in an asymptomatic patient? Well, we know that sensitivity for a lesion is limited. It has become apparent that symptomatic phenotype does not follow imaging. In fact, a very significant number of patients have compression by imaging based on CT scan. This is a paper from my institution in 2004 that looked at 50 consecutive patients with abdominal pain, no leg symptoms, no DVT history, and 24% of patients had greater than 50% diameter stenosis, compression on CT, and 66% of patients had more than 25% diameter stenosis. And you might say, well, that's only 25% diameter compression, but that correlates to 50% area stenosis, which up until now has been the dominant metric by which we judge the significance of a lesion. And so we know that patients can be asymptomatic and have a compression, making it all that much more critical that we consider the clinical context when we treat or consider treating a patient. So, stenosis, but no symptoms. IVUS identifies a lesion, but is it always clinically relevant? And that's a question we have to ask ourselves. We need to consider the clinical relevance. So to sum it up, I'm going to present the consensus statements, but specifically I've called out that my color commentary on each of the statements is in red. In a patient considered for NIVL treatment, an invasive diagnosis with the complementary use of venography and IVUS is recommended. And I wholeheartedly agree with this. Venography adds value in demonstrating physiologic relevant aberrant drainage or collateral drainage, and that just adds confidence to the diagnosis. Dynamic IVUS evaluation of NIVL is recommended. This includes breath hold and maneuvers that increases intra-abdominal pressure. And when you see a fixed lesion, you're much more likely to find that to be pathologic in the appropriate clinical setting, whereas dynamic compressions vary with such maneuvers and are less likely to be pathologic. And we showed an example of that just a bit ago. Using thresholds of over 50% area reduction, which has been the dominant cutoff for treatment, or greater than 61% diameter stenosis based on a small multi-center trial on IVUS at the NIVL, is correlated with symptom improvement following venous stent placement. Intervention below that stated threshold is not recommended. And really, my color commentary on this is that the 61% diameter stenosis with symptoms is my cutoff. It shouldn't be an eye test. It should be very obvious on IVUS. And area has not been proven to be valid in this small multi-center study, but clearly more work needs to be done in this area to find the optimal method by which we assess these lesions by IVUS. The use of venographic thresholds alone for the diagnosis and treatment of NIVL is less well established, and again, I would not advocate just using venography alone. And finally, axial imaging with CT or magnetic resonance imaging can help confirm the presence of anatomy that may be associated with a clinically significant NIVL. The final diagnosis and intention to treat, however, are based on clinical evaluation and venography/IVUS. And we know that non-invasive imaging can be a critical tool for workup in a patient with suggestive symptoms, but should not be the primary decision tool that you use to decide whether a patient should be treated or not. So many of these patients have workup. They often get bounced around. They'll often have axial imaging. It behooves you as a clinician to look at that imaging to see if you see something that's suggestive of it. But ultimately, if you have a high enough clinical suspicion, venography and IVUS are what we suggest to use to evaluate the patient. Thanks for your attention.
Thank you. Our next talk will be from Dr. Erin Murphy on some technical considerations for stenting.
Hi, I'm Erin Murphy, the director of the Venous Lymphatic Center at Saher Heart and Vascular, part of Atrium Health in Charlotte, North Carolina. These are my disclosures. As you know, today we're discussing the consensus statement on the management of NIVL lesions. That was a consensus on part of VIVA, AVLS, and American Venous Forum. Kush just talked to us about how to tell the difference between a pathologic and an anatomic lesion and which ones we actually should be stenting. I'm going to pick it up from there and discuss the technical considerations for stent placement. So how to pick the right size stent from length and diameter to prevent complications and have good outcomes. So once you have that properly selected patient with a fixed lesion, we're going to move on to sizing. So here is a patient that I'm going to walk you through, and you can see it plan here in the upper right corner. This patient has a significant NIVL and also has collaterals going left to right and reconstituting the cava. What I do first is I put my IVUS in place, confirm my lesion, and then I leave it in place while measuring the location of the iliac confluence first, because that is my cranial border of my stent edge. My goal is to figure a spot where the confluence is, and I can land my stent without jailing the contralateral vein. And then I'm going to move my IVUS distally, and I'm going to find a healthy segment of the iliac vein in the external iliac segment where it is straight in the pelvis. And that is my distal landing zone. Importantly, your stents should always land in that external iliac vein, and we'll go through why. The stents should never be shorter than 100, and I generally recommend 120 to 150 in order to really have a well-fixated stent and minimize the complications. The next thing I'm going to do is take multiple measurements in the common iliac vein and the external iliac vein. The average of diameters at these locations is what is closest to a stented circular diameter. So that's what I use to estimate the size of my vessel in the landing zone. My goal when I pick a stent is to have apposition in the common iliac vein with fixation in the external iliac vein. And I generally oversize my stents by about 2 millimeters in the external iliac. So here you see the same patient again, and down here you have your common iliac vein, which was measuring around 14, 148 area, average of diameters here just under 14. The external iliac vein, again, measuring around 14 average of diameter. So in this patient, I'm going to pick a 16 millimeter diameter stent. So here you see the patient's result. Here's the pre with significant lesion. Here's the post. You do see some spasm down here, but you want to make all decisions before you perform venoplasty. Sometimes venoplasty can make the vessel look a little bit better and you wind up understenting, or it can make it look spasmed and you wind up overstenting. So just make your decisions first based on your native vessel. Here you can see the IVUS results. Here's the Mathews with the confluence wide open. It was not jailed. Here's directly under the artery, and you can see it's well expanded. Then you're moving on to the common iliac and external iliac with good apposition and fixation, and a normal common femoral vein. So what happens if we get sizing wrong? The most discussed complication of missizing is migration. And here you can see a patient that was referred to me that has one stent here in the pulmonary artery, and then another stent here within the heart. And certainly these can have devastating complications. The patients can present anywhere from asymptomatic to needing extraction of these stents, either endovascular or open. They can have cardiac side effects with tamponade, arrhythmias. Some of them need open heart surgery, and there's even been deaths reported. So we do need to take our sizing very seriously to prevent this complication. So what we know is it's not associated with any particular stent, that all cases of known migration have been in non-thrombotic cases, and it's often in patients that really maybe didn't need a stent. It is always related to sizing and poor fixation. There was a review done that looked at 31 studies. Kush is actually on this one from 94 to 2020, and showed that 83% of migrations were in these short stents with less than 60 millimeters in length, and 94% occurred in stents that had less than 14 millimeters of diameter. So here's an example of a stent migration case. The IVUS and venogram was performed, and the operating surgeon estimated the MTS at about 80%. They selected a stent of 18 by 60. However, the 18 stents weren't available, so they remeasured and thought they would be able to use a 16 by 60 stent. Unfortunately, it immediately migrated to the IVC. When you're looking at the CT scan that was performed after migration, you can in fact see the stent here in the cava. But what's important is when you look down at the area under the artery, there really was no MTS lesion. And even more importantly, the distal common iliac vein and that external segment measured 17 and 16. So there really was no fixation for this stent. The wrong diameter and length is really what contributes to these migrations. Other complications can also be related to missizing. One of the more frequent ones is missed lesions. The stent can be forced back by the overlying artery and the pressure it creates on the cranial stent edge. This can only really happen with short stents that are secured only in the common iliac vein. If they're well secured in the external iliac, this will be prevented. Here you see two cases of stent where the stent was migrated backwards. The top one was able to be fixed endovascularly, and the bottom one required open surgery to fix since it eroded through. We need to make sure, again, we're on the straight portion of the vein, or those stents can erode through, as you see here. And oversizing is also an issue, so we do need to make sure we're within the window of correct sizing. Some of these patients have had to have stents removed for persistent back pain. So in summary, the consensus statements we covered. The first one, the choice of stent size and length in NIVL should depend on IVUS for diameter and length measurements with use of complementary fluoroscopy for length. Stent migration in NIVL can have devastating consequences up to and including death, and that we really need to take proper measures to mitigate this risk by using appropriate device diameters and lengths. The approach to selecting stent diameters in NIVL patients can be variable, but sizing should be based on the reference vessel, and this is normally the external iliac vein in NIVL cases. In the presence of significant compression, pre-stenotic dilatation can occasionally be present, but that is not the segment we should primarily use for sizing. Stents for NIVL should be extended into the straight portion of the external iliac vein in order to limit migration as well as the other complications we discussed. Thank you.
To discussion now, and there, Dr. Murphy may be joining us for the last discussion period. So I will turn this over to my co-moderator with the questions that came in from the audience.
Yeah. No, it's excellent. This is really excellent talks, very informative, and covered the statements very well. So few questions that came through. I'll first start with Dr. Elias. That was about, if the patient had, you mentioned about DVT, and patient has some VTE incident before, and they later were found to have a NIVL lesion. Is it something that if they had something in the past, how significant is the VTE to make it, an indication to place NIVL? Can you just elaborate on this more? Somebody had a DVT in the past, below the knee or popliteal. Is it something enough to consider it, or they need to be symptomatic from it?
Yeah, no, I mean, it's a good question, but I don't think if someone has had a DVT, infrainguinal DVT, popliteal or femoral, and then for some reason somebody decides to evaluate their iliac system for a NIVL, I'm not so sure that that's the one you're going to put a stent in. If, as I said, you're treating them for a thromboembolic event and they have a DVT that involves, their common femoral iliacs up say to the cava or to the common iliac, and you uncover a DVT, that may be somebody that you're going to consider placing the stent in at that time. But we've also had discussions at many of our meetings that, if it's kind of like not, as Kush told you, what's significant and what is not, it's kind of on that borderline, and they had some other reason, meaning they're on, birth control pills, or hormonal replacements, and or they had surgery. You may say, okay, the patient was doing fine until they had a second hit, so to speak. Maybe you don't want to, place that. If you have a clear-cut 85% diameter reduction, and they've had the iliofemoral DVT, that's the person perhaps that you should. But I don't think a remote history, and you just happen to find it because you're looking for it for some other reason. I don't know how everybody else feels, but I don't think that that's one that I would, place a stent in right away.
Good. I see a lot of nodding heads, which is good. Everyone agrees with that. All right, Kush, there's a question about imaging. One of the consensus statements talked about MRI and CT. The question is, do you get imaging on everybody if they have, coming with symptoms to help with the diagnosis? Do you get the axial imaging, ahead of time, and do you use it as a, kind of, a way to a tiebreaker, so to speak?
Yeah, and so there's going to be probably significant variability in this. I will tell you that I am fortunate that I get good quality axial imaging, whether it's CT venography or MR venography. The good fortune of working at an advanced imaging provider, imaging center here at Northwestern. And what it helps with is if somebody is being referred with leg swelling, pelvic pain, whatever it may be, and we want to just kind of get an idea of what's going on. The axial imaging, if you see even a slight indentation, and then you talk to the patient and the symptoms might fit, then you start going towards maybe doing the invasive workup. And if your IVUS is not going to show anything, then you don't do it. But I'll tell you, there have been plenty of times that I'm referred a patient, I look at them, it's very clearly lymphedema, the big cylindrical leg. They might even have contributory history, prior pelvic surgery, prior orthopedic surgery on that side. And there's absolutely no contact whatsoever of the artery on the vessel. You don't need to do IVUS. There's just not going to be a compression there. So I think it adds enormous value. And again, especially in the United States, there's probably not too many patients that don't have a CT or of some sort in their remote history that is available for you to view. I mean, half the time I don't even have to order one. It's there.
So a quick follow-up to this, you mentioned lymphedema. Just so a quick question came up. Somebody with a C3 disease and possible NIVL, do you rule out lymphedema before considering a stent? I don't know. Maybe Raghu, do you want to?
Yeah, that's a great question. So I think C3 is probably the most wastebasket and difficult term we have in venous medicine. What does that mean? Your big toe is swollen or your whole leg is swollen? You're both C3. And so I think it's deeper than that. And lymphedema just has a look, right? You have a Stemmers, you got the hump, you got featureless malleoli, and many of them don't have venous claudication. And I actually find venous claudication particularly a useful metric. And unfortunately, we don't have that well categorized, and that's something that we need to do a lot better on. But isolated edema, I'm not all that hot on a stent being able to fix that in the absence of anything else.
Raghu, can you comment on it since you're
Yeah. Thank you, Saher. We see this all the time, right? Today in my clinic, I diagnosed 2 knee arthritis, which were referred to me as possible NIVL lesions. So whether it's knee arthritis leading to, thigh and ankle thigh and knee swelling, or whether it's lymphedema, patients who have had up to their eyeball stented, all of these are not appropriate. And we, in the paper, have a differential diagnosis, not just of lymphedema, but what are the edemas that cause usually bilateral edemas, and what are the ones that cause unilateral edemas, and some both. So it is important to understand all the different concepts and take care of the patient. Like Steve always says, don't treat the image, treat the patient.
Great. Erin, a bunch of questions about, techniques and stuff. Excellent talk. So just I'll hit you quickly with them. So when you do telescoping 2 stents, can you say, do you start cranial versus caudal first? And do you have to match the size? If one is bigger than the other, which one do you start with first?
Yeah, so I typically will put the lower stent in first. I changed my practice when I switched over to nitinol stenting. I used to stent top down. Now I'll put the distal stent first, typically a 14, and then I'll put the 16 cranial stent after that, so that it kind of fits in nicely with a good taper. And I will say, for the last question, I do image the lymphedema patients at least once. I have caught quite a few of missed disease. I mean, a May Thurner is not going to cause a lymphedema presentation, but I had a guy with bilateral lymphedema on disability who had a caval occlusion. So just because it does cause secondary lymphedema when they're that bad. So just kind of think about that in the background too.
Okay.
Yeah.
Go ahead, Steve.
Yeah, no, I just want to make a point. What Kush was saying about, axial imaging and stuff. I'm not as big of a fan as him, and it's not because we don't get good imaging. We do, and if we see something, we're going to do an IVUS and a venogram. And if we don't see something, I'm really convinced it may be venous. I'm probably going to do an IVUS and venogram as well. But that's not the point of what my conversation is here. It is always remember, everybody, sometimes you do need a CT or MR based upon you're looking for some other pathology within the abdomen or pelvis. Now, if someone tells you they've had swelling for years, that's one thing. But if they said they've had swelling for the last few months, you may want to consider some tumor or something else. So that is always a good reason, even if you don't think it's a nipple, to get some axial imaging, looking for other pathology.
Great, you answered the next question, which is awesome. Thank you.
No,
So,
you text me the question, so that's why I answered.
I know. I actually did not, but actually, you're a mind reader. That is amazing. All right. Another question about ballooning. Do you like to pre-dilate balloon and ahead of stenting, or do you just balloon after stenting? And how do you size that? So I don't know if Erin would comment on this. Maybe Jay, you can comment afterwards.
Yeah, I pre-dilate to size of the stent I intend to implant. So if I'm, the CIV 16s usually, and distal is typically a 14, depending on the size of the stent I'll use.
Good.
I think, can I make one point about the ballooning?
Please.
Another, I think, very handy thing when you're ballooning to size, or why it's a good final safety measure, is when you have the balloon in place, see whether you can move it back and forth. If you can move it back and forth, you have the wrong size, and your stent's going to fly. So I think it's a good final safety measure to see whether or not, and you can also see whether contrast moves around it. So I think that's a great thing to do when you're pre-ballooning.
Love it. Jay, any comments on the ballooning pre and post?
No, I've done it both ways. I do agree that pre-ballooning, especially to the right size, especially with that technique as well too, you can get fooled a little bit too if there's a significant size differential, which is why Erin's point about using longer stents is really appropriate. You want to right size to the more to the distal point. The problem is you also want to be oversized too much because you get that Poisson effect as well too, and then you can get tenting, which can lead to other problems as well. So sometimes I will use two different size stents to try to taper them, and again, you put the smaller stent in first, and you put the larger stent in thereafter. Just make sure you have appropriate length to make sure that there is a migration.
Yeah. Just a final technical point we didn't discuss. Everybody's talking about ballooning pre-stenting. But Kush and Stephen Black make the point, and I learned this from them many years ago. Post-stenting, even if it looks great and opposed and everything else, post-stenting, because of the nature of the stents, of the material, will increase the strength of the stent a significant amount. So even if it looks perfect, I think it should balloon post-procedure. I mean, Kush, you have any thoughts on that?
Yeah, I mean, it's actually a metallurgy issue, and we won't bore anybody with it. But nitinol does not reach its final, most stable, most rigid state unless a load is applied to it via a balloon. So you have to do it.
Okay,
and of
so
course,
that's
you're
going to
careful with
the first question section, and we'll have more time for questions at the end, but we're going to now hear from Dr. Jay Mathews on the optimal medical therapy and surveillance for patients who are treated with a NIVL.
Hello, I'm Dr. Jay Mathews, and I have the pleasure of today talking about optimal medical therapy and surveillance for patients with NIVL. So consensus statements that we have come up with regarding this topic: the routine use of anticoagulation or antiplatelet therapy for untreated NIVL is not supported. in treated NIVL patients with no evidence of previous venous thromboembolism, either by imaging or history, there is no consensus that anticoagulation or antiplatelet therapy is necessary. An assessment of thrombotic risk in NIVL patients should be made. If anticoagulation or antiplatelet therapy is indicated, the agent, dose, and duration should be tailored accordingly. And finally, routine, early, and long-term clinical surveillance, including imaging of NIVL patients following stent placement, should be performed. Imaging to assess the stent is per practitioner preference, i.e. either ultrasound or axial imaging, and attention should be paid to stent-related adverse events such as migrations, stenosis, and thrombosis. So with those statements in mind, I'd like to break those down individually. So let's first talk about treatment of patients who are asymptomatic with NIVL. So NIVL, first of all, is a very common condition, as we heard earlier. In a series of 50 patients who presented with abdominal pain, mean age 40, most of these patients were female. There was incidental left common iliac vein compression seen, or NIVL, in 25 to 66% of patients. So 25% of these patients had greater than 50% compression. 66% had greater than 25% compression, which correlates to about a 50% stenosis. But none of these patients had prior DVT. In another series, they found that 2 to 5% of patients had NIVL in DVT. So prior DVT alone does not always mandate treatment. And in a series of DVT patients with iliac compression, 66% of these patients had another contributing factor as to why they ended up having DVT. So simply having isolated compression does not warrant pharmacologic treatment in a prophylactic manner. So what about antiplatelets versus antithrombotics? High patency rates are possible regardless of whatever regimen you choose, whether it's anticoagulation, fully therapeutic, low-dose anticoagulation using antiplatelets, or low molecular weight heparin. Now, a Delphi consensus statement was produced in 2018 that suggested low molecular weight heparin for 2 to 6 weeks and ultimately a DOAC afterwards of 6 to 12 months. But subsequent data have suggested there's really no difference with regards to outcomes, whether or not you use DOACs or no DOACs, or subtherapeutic regimens versus therapeutic regimens. Ultimately, Zhao and Desai found in their series, patency was high in the NIVL cohort, so 99%. So routine anticoagulation or antiplatelets may not be recommended. So what do you do? What regimen is appropriate for these patients? Because ultimately something may be necessary depending on the individual. And that really comes down to the patient. So you really want to tailor the therapy to the NIVL stented patient. So if you are going to put a stent in this patient, look at their overall risk factors. And this comes from an AJR review, looking at what is their risk for thrombosis? Do they have an underlying clotting disorder, inflammatory conditions? Do they have malignancy? Also, technical factors as well too. Is there excess stent material, low flow, or stasis? These types of risk factors may potentially warrant some type of high level of either anticoagulation or potentially antiplatelet therapy. Some of these patients will require single agent therapy. Some may require multi-agent therapy, so both antiplatelet and anticoagulants. However, the agent dose and duration really remains unknown because there's not enough studies out there to really support one regimen over the other, and this remains an area of research. So what about surveillance imaging? So why do we need to do follow-up imaging in these patients if patency rates are so high? The reality is complications can occur. We all recall what happened with the VT stents with regards to stent migration. Some of that may have been potentially related to undersizing or shorter stents being used within that patient cohort. But ultimately, even with other types of stents, if you look at the MAUD database, even the Abre stents, which were oftentimes longer, sometimes did migrate as well too. So complications can occur even though they are rare. But you can also have thrombosis and occlusion, which is also rare as well too. As I mentioned before, stent patency has been reported as high as 96 to 99% in most populations. So even though the reality is that these stents do tend to stay open, sometimes they do stenose, and sometimes they do thrombose. So some type of surveillance is recommended to look for things like patency, migration. And ultimately, at the end of the day, we just don't know about the newer generation venous stents because we don't have long-term data. We do have longer-term data with wall stents, but the reality is with the dedicated venous stents, they haven't been out long enough for us to really know what their performance is going to be over a period of decades. And so how often you should be doing some type of surveillance versus also how long still remains an area of study. I can tell you that in my own practice, typically after implantation, I will do a repeat ultrasound at about 1 month, 6 months, and 12 months, and then really annually after that. Others will choose different types of surveillance regimens, and perhaps the amount of metal, the patient's comorbidities may dictate what type of surveillance regimen you choose. So I'd like to go through a clinical case here. So this is a patient presenting after having had a wall stent placed for NIVL in the left common vein 7 years prior. So she's 76 years old, now right brain of the left leg swelling for over 4 weeks. She was on antiplatelets, but was taken off of anticoagulation by her primary doctor about a month prior. So if we take a look at this particular patient, this is now in the prone position. You can see we've had contralateral thrombosis. And based on that history, you can probably guess what happened. And so you can see here, after performing thrombectomy, we're able to restore flow. You can see that with the wall stents, they have a closed cell design, and they had very poor radial force at the edges. So we tend to have to deploy those higher up into the cava. But the problem with this is that you end up jailing the contralateral limb, and you can see here that that area, there's some stasis there too. It's pinched, and so this is due to contralateral thrombosis related to the wall stent. Ultimately, ended up going behind the stent, extending up now with 2 dedicated venous stents, and reconstruct the iliac vein bifurcation with excellent results, and ultimately the patient's symptoms did resolve. So you can see this is both acute and chronic thrombus that was removed. As I mentioned, the wall stents had poor radial strength, closed cell design, and then also obviously after the stents were placed, we have increased metal density and stent burden. So what can we conclude about the pharmacologic recommendations here? Well, ultimately, retrospectively speaking, this would have been a long-term DOAC type situation. I don't think I would have taken the patient off of anticoagulation. And ultimately, of course, now this patient's converted from a NIVL patient to a thrombotic patient. So potentially longer-term DOAC is recommended anyway. Also, there's more metal here. There's a higher stent burden. I think this patient probably should remain on long-term DOACs as well. Studies will have to show if this makes sense. And then ultimately, hopefully with further research, we'll be able to give you better recommendations in the future. Thank you very much.
Okay, our final talk before we go into another discussion is going to be from Dr. Kolluri, and he's going to talk to us about future directions.
Hi, I'm Raghu Kolluri. I'm one of the VIVA board members and also authors on this consensus document paper. I'm going to talk to you about the future directions in the NIVL research and education. These are my disclosures. In regards to the future directions, we came up with 3 consensus statements. The first one basically recommends that there be long-term prospective trials in patients with NIVL and concentrate not just on the stent patency, but also patient quality of life metrics and also appropriate patient selection, proper technique, post-procedural medical management, and also surveillance. The second statement calls for establishment of consensus guidelines with multiple societal endorsement. For example, all the vascular, cardiovascular societies that are mentioned here, such as ACC, SCI, Society for Vascular Medicine, American Venous Forum, et cetera, et cetera. Finally, the third statement also says that for the future, NIVL education is important, and as such, dissemination of these guidelines, which are multi-societal endorsed guidelines, need to be disseminated appropriately. And because these patients are treated by physicians who may or may not have good venous education exposure in their training, they might need some additional postgraduate training so that they understand the etiologies that can mimic the symptoms of NIVL. For example, the paper alludes to the different causes of lower extremity edema. And there's a whole list of that, as you can see in the table here. Similarly, the pain also could be a component of, for example, a neuropathy of some sort, or maybe they have skin changes that has another dermatologic manifestation. So the treating physicians need to understand those etiologies that could potentially mimic the NIVL presentations. Finally, within the same guideline, apart from the societal endorsement, we also state that the physician should adhere to the standard of care and also participate in the tracking and reporting of their quality outcomes publicly. So those are the statements, and we go on to talk about other issues and challenges and future directions in the NIVL space. And we acknowledge that there is paucity of level 1 data. We still don't know who benefits the most. We don't know whether the determinants of success, it's not just anatomic success or improvement of flow. There is still no RCT to date comparing conservative therapy to endovascular therapy. There are numerous quality of metric scales, as you can see, from SF36 all the way to CDQ, but there is no consensus on a single quality of life metric that accurately measures or assesses NIVL treatment. We still don't know what the appropriate post-intervention pharmacotherapy is. We still don't know what the surveillance cadence should be in these patients. We don't know how the patients who are underrepresented and at-risk population are being treated with NIVL. So all of these are challenges, and that we have currently, and hopefully future research will answer these questions. Well, I talked about the manuscript itself, and then I wanted to throw and end my talk with a couple of slides of what I think as I treat these patients every day, Monday through Friday in my clinics. When I see them, I hope to get some good data and take that evidence-based medicine and answer some of these patients' questions and improve my thought process. If I have a patient in front of me, who will benefit from it? How do I diagnose this patient, not overdiagnose or underdiagnose, both clinically and with imaging? Whether that is duplex imaging, axial imaging, venography, or IVUS. How do these lesions change with positions? There's data that standing position may change the NIVL lesions, and recumbent position may overestimate the compression of the NIVL. How do you accurately measure NIVL lesions and IVUS? And once you have all of these, how do you know what is a hemodynamically significant lesion? Is the NIVL lesion in isolation causing the classic symptoms similar to the NIVL lesion in a patient who also has superficial venous reflux? Or is it similar to the NIVL lesion in a patient who also has post-thrombotic changes in deep venous reflux infrainguinally, or a combination of venous reflux and obstruction infrainguinally and a NIVL lesion? So how do you parse that out? I hope we have enough data to maybe 5-10 years from now answer these questions. And then eventually these are the patient questions that I get asked in these patients. And I hope I'll be able to answer, okay, if your NIVL is treated, you will not need to wear compression socks. Note an improvement in your leg symptoms. Your ulcer will heal faster. maybe your varicose veins will go down, your risk for blood clots in the future will go down, or you'll need ultrasounds every so and so months and it'll cost you X amount of dollars. These are the questions that my patients ask. And now we don't have that data, but hopefully we will. Patients also will ask, and we might have to tell them that what are the things that, and confidently do so, that NIVL treatment will not improve. For example, lymphedema. NIVL treatment will not cure your lymphedema. You will not be able to come off of your blood thinners if you have a, let's just say, hypercoagulable state and NIVL. And certainly, some patients have asked me if it is true that a certain doctor told them that it'll cure their ED, and can we confidently say that they will not that treatment of NIVL will not cure their ED? So all of these questions, I personally hope we'll have information about in the next 5 to 10 years. Thank you so much.
Thank you very much. And so now we have another period for Q&A, and we'll see what questions you have for us.
Yeah, I mean, we have a lot of questions coming through, so I'll try to summarize them quickly. Just Raghu, quick comment on the just lymphedema part. Seems to be a lot of questions about it, or just, if you're just going to comment a little bit more about, especially if patients have like lymphoma and had lymphedema and compression of the vein. Do you want to just make a quick comment on it before diving into some other questions?
Yeah, I said it won't cure lymphedema probably. Erin said IVC occlusion can cause lymphedema, and someone else, I think it's Steve, who said that if it's abrupt onset, you get axial imaging to make sure that there are no compressive or lymphadenopathies, etc. All those are right. What I don't want our audience to take away is that every lymphedema patient needs to get their IVC started because Dr. Murphy, the great Dr. Murphy, said that. That's not what she said. I hope you agree with me, Erin. There is the difference between lymphedema by itself and phlebolymphodema, and how the natural history is and how the legs look like. So I just want to make sure that that's out there, that yes, IVC occlusion can definitely result in phlebolymphodema, definitely. But that presentation is significantly different than patients with lymphedema, either primary or secondary. Thank you.
All right, question about antiplatelets therapy. The European guidelines talk about monotherapy with antiplatelets. Several of the stent trials included antiplatelets. In the consensus, we mentioned that there's no definite benefit. I'm sorry, exact the wording. So any comments on this? Anybody wants to take that on?
If I may, I can say.
Go ahead.
Yeah. So as the medical guide almost makes sense. It always, we read in medical school that the intrinsic pathway kicks in if you heard the endothelium, right? Somehow patients are doing well, but there are still some practices that still use anticoagulation. There's not a single study to date in regards to access site complications from venous stenting with ultrasound after each and every procedure. If you take the Perclose data, for example, in EP patients, it's about 20%. Jay mentioned several aspects that could if you want to tailor therapy, you could use those, but I don't think there's a straight answer.
No, there's no data really.
The length of this, I just quickly on it, and I'll let you answer it. So another question, you can lump them together. So, but the length of the stents, what's excessive metal? What exactly is this? There was a question about it.
Yeah, I mean, that's also not been studied, right? So we know there's a lot of different stent designs, open cell versus closed cell. Now most of the modern generation stents are moving towards more of an open cell design. So there's going to be a little bit more free cell area. But if you overlap stents on top of each other, if you have a lot of stent length, if there's more venous stasis, so if the flow dynamics are not great, these are all things that potentially can lead to more thrombosis. So we know that inflow is very important to stent patency. If any of these things are compromised, it may lend towards a stronger, maybe anti-thrombotic regimen. But again, we don't have really data to support that. So it's all just recommendations. And if you talk to multiple different people, you'll get multiple different answers.
Yeah, but Jay,
All right.
let's not
Go ahead,
let's
Steve.
not have our listeners, we're mixing apples and oranges here. We're speaking just about nibbles, and specifically
Correct.
about nibbles. We're not concerned with inflow 99.9% of the time.
True.
We're not concerned about outflow. And I think what should be taken away is what Erin made the point. You want longer stents in general, planted in the mid-external iliac vein once it's come around the curve. And I think most of the studies show it's not the amount of metal in the vein that causes a problem. It's your inflow and outflow issues. And anybody who's thinking that veins and arteries are the same, the only reason they're the same is they both carry blood. After that, they're totally different. You can't think of antiplatelets in the veins like the arteries. You can't think of, everything else, shorter, longer, whatever. That's what we really want them to take away here, that we're speaking just about nibbles, not post-thrombotics. And probably most of the time, you don't need to anticoagulate or antiplatelet. As Kush's data and other have shown, the patency rate is just so high in a pure nibble.
And I agree with that. So it's truly a pure nibble case. The patency rate's extremely high. You can do absolutely nothing. It'll be fine. I think there was some points brought up about some of these hybrid type patients who have mixed features. And I think you have to individualize the therapy for those patients. But the reality is, again, we don't know. I think most people do fine with nothing at all.
Good. We're going to go over because there's a lot of questions. A lot of people are still logged in. So if they want to listen to us, we'll keep talking. So Kush, so just to give you a scenario about, and it was mentioned here that after stenting in follow-up, you do and you have some loss of physicity in the common femoral vein, and on imaging there's some not full thrombosis, but maybe instant stenosis or non-occlusive thrombus. So how do you manage this? Do you change your regimen for this patient down the road, or there's some asymptomatic, for example, do you do IV?
Yeah, so it's a great question. The first thing is, what are the symptoms? Am I treating them or am I treating myself because of the picture? And if the symptoms have returned and you have loss of phasicity, then you start talking about, okay, did I oversize a stent to the inflow lumen? It hasn't accommodated. It's laying down because the periphery of the stent is subject to non-laminar flow, whereas the central portion is laminar flow. It doesn't happen really. I mean, it's never happened to me with nibble. And so if you're sizing in range, it probably shouldn't happen. But if the patient is asymptomatic and you have loss of phasicity, you really have to ask the question, why is there loss of phasicity? Is it because the stent is, now maybe crossing over the ligament into the common femoral vein? You've now changed the modulus of that common femoral vein to be stiffer. It's no longer a bag that is compliant that's going to change with pressure volume curves. It's basically a collagenized metal tube. And so symptoms have to be your guide.
Good. Erin, any comments on this? What do you do? Same? Anything?
Yeah, I agree with that.
Excellent. Good. A quick question about using IVUS contralaterally to help with placement. Do you see any value for this?
I'll just start there. I think it can be problematic. Iliac veins are not equal. The word is anisotropic, but basically the left iliac vein is curved. It's longer. The right iliac vein is shorter. And, especially if you have a very significant obstruction and you have significant cross-pelvic collateralization on your venography, it's entirely possible that a significant portion of the blood volume is going into the contralateral vein and you will have the wrong size. So I personally never use the contralateral vein to size the stent, the segment where I'm going to place a stent.
All right. Okay. Kathy, there's a question specifically to you. about pelvic congestion. And there's a question about overdiagnosing, this condition, NIVL, in pelvic congestion. I know we mentioned it in our consensus statements. There's a worry that being mentioned in the consensus statement would even lead to more, stenting. So can the request is a word of caution, or just some thoughts from you on this?
Yeah, that's certainly a good concern, and there's some papers out there that suggest to primarily stent for pelvic disease, or that it may be, or pelvic venous disease and pelvic pain, that it may be preferable to ovarian, doing embolization for ovarian veins first. And I think that there's a lot of us that paid some attention to that, but that's not quite what we find in our own practice. Actually, Kush and I were talking about that recently. That I think that you need to be cautious, because women with chronic pelvic pain and pelvic venous reflux are invariably thin women. And I think it's really easy to misdiagnose a NIVL, particularly if you don't do careful positional testing like Kush was showing, that you can really easily get fooled. And to a point, I think that Steve made, if you're going to be doing stenting for pelvic pain, you really want to see the right hemodynamics, that you're seeing, reversal of flow down the internal iliac, and that you're seeing that the varices are coming from there. And if I see both, if the patient does not have also leg symptoms, I'm usually going to treat the ovarian vein reflux first, like if they don't have a swollen leg or venous claudication or something like that. That being said, I do have some patients that have had both symptoms and their leg has been equally symptomatic, and they have a swollen leg, and it all works out for being a NIVL, and I've treated some of them first. But I think you do need to be very careful. And I think that the complications that you can think of from mistreating a NIVL, the migration, the back pain, the things that you can have, are more significant than the complications that we see with gonadal vein embolization. You can have coils migrate. Knock on wood, I've never had one migrate, but that's, I think, less likely to cause major problems than putting a stent in someone that didn't need a stent. I don't know if any of the other panelists feel differently, but that's my take on it.
Oh, agree.
Yeah.
Excellent. I think we covered almost all the questions that we have here. So I think a lot of repetitive stuff. So I think that was great. Kathy, take us home.
Yeah. So I just want to thank everybody, for spending time with us. There's other things you could be doing with your evening, and you've decided to spend part of it with us. So we really appreciate that. And we hope that you've found this to be a helpful conversation, and that we will continue working on narrowing this knowledge gap that we have, this evidence gap, to provide the best care for our patients. And we do encourage you to come to the VEINS meeting, come to the VIVA meeting, where you can see many of us in person and answer any questions face to face that maybe we didn't get to. So again, thank you for your time with us this evening.